Hi, this is Eric Ruderman coming to you from Chicago, Illinois for Room Now. And I'm going to talk today about some of the future of treatment for psoriatic arthritis. We've come a long way since etanercept was approved almost 20 years ago now. And we have a whole host of treatments, and I think we're looking forward to some new opportunities in the future. And I kind of want to touch on a few areas. First of all, I think after years of waiting, we have sort of finally sort of opened the door on effective, very effective small molecule therapies in psoriatic disease. Initially, Premilas with some level of efficacy, but not nearly the same as a biologic. But now the JAK inhibitors, which seem to be very effective, particularly for joint disease, and in at least one instance for upadacitinib, reasonably effective in skin disease. And I think that, looking forward to the future, the question is going to be, how much are we going to drift over into small molecule therapy as opposed to biologic therapy with parenteral administration, which, at least some patients continue to find challenging. Some of this is going to depend a lot on how things shake out, both with data and just sort of community and patient acceptance of JAK inhibitors, given some of the more recent data in RA on cardiovascular and potentially malignancy risks with tofacitinib and how much that spills over into other JAK inhibitors. Along those lines, I think one of the things we're looking forward to with some excitement is the advent of the TYK2 specific inhibitors. So TYK2 is really the fourth member of the JAK family. There's JAK1, JAK2, JAK3, and TYK2. And we've seen some data in both skin disease and joint disease with deucravacitinib, which is a TYK2 specific inhibitor, likely to be available to us in the clinic in the next few years. And I think we don't yet know whether this is going to carry some of the same safety risks or concerns that the other JAK inhibitors have, or perhaps because of its more specific mechanism of action blocking TYK2, maybe there's a safety benefit here. The trials seem to suggest that. I think it's a tough one to go from trials to practice, to particularly for things like safety, to know what the real incidence is in the community. The advantage of the TYK2 inhibitors is that IL-23 signals through TYK2, suggesting that this might be a more specific target for psoriatic disease, knowing the benefit of inhibiting IL-23 signaling in these patients, certainly for skin and more recently for joints. We've also seen some early information, and maybe we'll see these down the road, on so-called dual inhibitors that may block different members of the JAK family, and more so than some of the earlier JAK inhibitors that just weren't very focused. These are actually specifically targeting different members. Whether that's going to add any benefit, or it's going to be like some of the experimentation with a combination IL-17 TNF inhibitor that really didn't add much value over either one alone. We'll see, but that may be something that's coming in clinic. And actually, along those lines of sort of the mechanism of TYK2, there's the prospect of trying to understand in the future where IL-23 inhibitors fit into our regimen. Very effective for skin disease. 2 have now been approved for joint disease. They're certainly effective. I think in practice, clinicians don't really have a great feel. I certainly know I don't, for how effective they are relative to the existing therapies that we've been using. And so, I think both based on our experience and a couple of solid clinical trials, we have some data that says that IL-17 inhibitors and TNF inhibitors are pretty comparable, at least for joint disease and psoriatic arthritis. It may be that the IL-23 inhibitors sort of fall in that same bucket, but I don't know that we really know yet. We have no comparative data, and I don't know that we all have enough experience in clinic to have a good feel for that. But we'll see, and I think that's going to help us decide who belongs on what. And I think a lot of that is going to take time as we understand how we target in these patients. And that's really the future. Another future thing that we're looking at is sort of which aspects of disease are we focusing on. In some other videos on this site, I think you'll hear some about patient outcomes and the idea of using things like a minimal disease activity as a target for therapy, which includes both skin and joint response. And so as we start to weave those into our management strategy, I think we're going to have to look more at the different approaches and the different treatments to see what's going to work better for skin, what's going to work better for joint, and in each individual patient, which is going to be more appropriate or which is going to address that aspect of their disease that's more of a problem for them. It's one thing for us as a physician to say, well, here's your problem and this is what we're going to treat. I think we really need to engage our patients to try to understand what's really most concerning for them. And within the limits of our kind of responsibility to make sure that they're being treated appropriately, they need to sort of guide a lot of those choices because people have different values, different concerns. I have patients who are much more concerned about joint disease than their skin. I have patients more concerned about their skin than their joints. And you have to take that into account as you're making therapeutic choices. And I think that's one of the things that we're going to be struggling with as we move ahead in managing psoriatic disease. And then finally, I think the other interesting sort of future possibility is the prospect of combination therapy. Historically, we've been very concerned about combinations of biologics in our patients. And I think this goes back to some of the early trials many years ago in rheumatoid arthritis, where TNF inhibitors were combined with IL-1 inhibitors or TNF inhibitors combined with abatacept. And in all cases, there didn't seem to be a clear benefit in terms of efficacy, but there clearly was a safety issue, particularly in terms of a higher risk for serious infections. And so I think we've been very gun shy about using combinations of biologics over the years since then. But with some of the newer agents, particularly things like IL-23 inhibitors, that may have a better safety profile in terms of risk of infection, is there going to be value in combining biologics? And in fact, there's an ongoing trial right now combining golimumab and guselkumab, a TNF inhibitor and an IL-23 inhibitor for treating psoriatic arthritis. And I think that's the way we're going to need to do it. We're going to need to look at the data from a trial to determine whether it's truly safe. And then we're going to need to look at the data to decide whether there's an efficacy benefit and whether it's worth combining therapies, or whether we don't get enough added value from the second agent to be worth the risk. I would be remiss if I didn't mention a combination that many of us have been using so far and may be using more in the future, and that is a Premilas combined with a biologic. Certainly a Premilas has a great safety track record in that it is not a significant immunosuppressive agent. And so I think we feel more comfortable when we can. There's clearly a cost issue there by combining that with a biologic. And many times that's a challenge with insurance. But I think if we learn more about where that particular combination is most effective and most useful, it may give us a chance to work with our insurance companies and our PBMs to try to get that for patients when it seems to be appropriate. And then finally, we're still on the cusp, as we seem to be consistently for the past few years, of personalized medicine. And this is certainly an area where that's going to be very helpful, trying to understand why some patients have more skin involvement, so others have more joint involvement, or enthesitis, or dactylitis, or uveitis, et cetera. And then trying to tailor our therapies to that. It's early days, but I suspect that in the not too distant future, we'll be able to use some tools from biopsies. Certainly skin biopsies are easy to get. Synovial tissue biopsies, a bit harder, but not impossible, even in clinical practice. And we may get enough information from some of those to help us, like the oncologist, really guide therapy based on a particular patient's biology. So, to sum up, I think the future of psoriatic therapy, both for skin and joint disease, is bright. A lot of opportunities. We have great drugs right now, and we're going to learn more about how to use them specifically for the right patients. And we're going to learn how to weave in some of these newer mechanisms of action to find a way to really get our patients' diseases under control and let them get on with their lives. Thanks for listening, and I hope you'll join us on Room Now for some of the other interesting videos dealing with psoriatic disease.